This is Rich Slama, and today we're going to be talking about appendicitis in the 5-minute lecture series. So, classically, these patients will present with periumbilical abdominal pain that radiates to the right lower quadrant. In males, they can have pain radiating into their testicles. Females can also have other nonspecific symptoms. They can have anorexia, they can have nausea, they can have vomiting, pelvic cramping, and so the real diagnostic dilemma with this particular disease process is distinguishing it from other potential diagnoses. So this is just what I said. Keep going. So the diagnosis of this, there's numerous physical exam maneuvers that we can use to help diagnose this. None of them are 100% specific, so I wouldn't necessarily rely on those. Unfortunately, lab work, it can help you, but it is not necessarily sensitive or specific. Patients can have an elevated white count for numerous reasons. A urinalysis is helpful in some instances, so if it's normal, that kind of leads you away from a urinary cause of the symptoms. Although if there is just pyuria, that can direct you towards an appendicitis. So let's consider that. Anybody with abdominal pain, you of course want to consider hepatic function testing. And then all female patients in the emergency department with anything close to abdominal pain should get a urine pregnancy test. And then we're going to also go into some of the imaging, which I'll review next. So as your psoas sign, you get the patient to lay on their side and passively extend their hip. And the mechanism behind this is that if they have a retrocecal appendix that overlies the psoas muscle and there's irritation of the psoas muscle, they'll go ahead and reproduce that pain that they were having previously. This is the obturator maneuver as described. I don't really do this too often because I just haven't found it to be overly sensitive for the diagnosis. And then how do we image these patients? I would say that if all you have is an abdominal x-ray, then it can help because there's some secondary signs, such as the fecalith or there's an ileus, but there's nothing that you can 100% diagnose with a plain film, so that would not be my first go-to test. On the other hand, a CT scan of the abdomen and pelvis with IV contrast is actually the best study. And you can also add oral contrast as well for some increased sensitivity. And you're going to be looking for an evidence of an abscess, dilation of the appendix, usually greater than 7 millimeters in the right lower quadrant, and some fat stranding, which is just kind of this nonspecific, stringy looking inflammation down here. And if you're really, really good, and especially in kids these days, ultrasound has become exceedingly popular for diagnosing this condition, mostly because it doesn't use any type of radiation and it poses almost no risk to the patient at all. The main problem with this modality is that the appendix cannot be found 100% of the time. And actually, probably in my own experience, only about 60% of the patients actually get their appendix found. And a lot of it is very operator dependent. Just know that if they see an appendix in the right lower quadrant, and it's usually greater than 7 millimeters, there can be some free fluid that's visualized as well. That definitely helps in diagnosing these patients. So, there's really a couple of different pathways that you can go down. Either you work them up and they don't have appendicitis, in which case you can reobserve them in 12 hours. If they have appendicitis and you've excluded all of the causes, you can sometimes get away with not even getting a CT scan of the abdomen. And then if it's might be appendicitis, but there's not 100% slam dunk clinical signs, your labs are maybe suggestive, but there's nothing definitive, then you want to go ahead and get a CT scan. But it never hurts to give your surgeon a call to see what they prefer. So in terms of the treatment, any patient who has suspected appendicitis should be made NPO. Go ahead and start some IV fluids on them, as usually they've been vomiting. And then most of these patients, before they go to the OR, will get antibiotics of some type. These can range anywhere from a second-generation cephalosporin all the way up to piperacillin, tazobactam, or Unison. A lot of it is surgeon-dependent. And then always control these patients' pain, because even though in the past it was said that controlling the pain will actually ruin the physical exam for the surgeon, that has subsequently been debunked. And so analgesia for these patients is of utmost importance. And just a few pitfalls. You have to make sure that this is nothing else that could be causing these symptoms. So ovarian torsion can cause these symptoms. Testicular torsion can cause these symptoms, sexually transmitted diseases can cause these symptoms, and pregnancy can cause these symptoms. So these are maybe at least some of the major diagnoses that you want to make sure that you exclude before you consider CTing or calling your surgeon. And that is really it, and I hope it was useful, and we will see you all next time.